So hello, everyone. I'll refrain from saying good morning like I usually do on the wrong side of the world. So I hope you all are having a good day. Both the University of Munich and the University of Berlin for about 10 years before she opened her own practice in Berlin, which she's had private practice for ophthalmology now for over 20 years. She probably didn't want me to say that part. But Ingrid has been very active in the ECVO as well, and formerly also the president. So I think there's a real big pause. So I'm going to turn this over to Ingrid without further ado. I'm still getting all the feedback from my introduction, so I apologize for that. All right, so I'm going to turn it over to Ingrid. She's going to now start the presentation.
Okay, hi everybody. I hope my audio is fluent and you can hear me well. If not, please send through the chat some messages to the host and we will try to arrange it. So the topic is new diagnostic opportunities for the image presentation of the tear film and the meibomian glands, and we need to be on the same boat regarding some basics, and I'm just quickly reviewing things that you know and you learned and it's all there, but we need to be clear on terms, and I think it's always good to have a review to start with. So we agree on that the tear film forms a smooth optical surface just by filling irregularities on the corneal epithelium. It keeps everything moist, the cornea, the conjunctiva, the lid margins. It serves as a lubricant, and it transfers O2 to the cornea. So it's a really important structure. It washes away debris and irritants, and it prevents the cornea and the conjunctiva from infections. Also, if you think about how white blood cells get into the game, it provides the pathway for that as well. So the tear film is composed of mainly water. That's 98%, it's only water, and salts are dissolved within that water, and some proteins as well. And if you watch on the protein content of unstimulated tears, it's like 2 grams per 100 mLs. And if you look at the stimulated tears, and we'll get to that later, what this is and how this works, the protein content is really low, and you can imagine that also the ingredients that compone the protein content will be really low. So the stimulated tears will be of less quality than the unstimulated tears that come from the lacrimal gland and the accessory glands. So here's what you know: the tear film, it consists of the mucin layer, the aqueous layer, and you can see here in the graph that the aqueous layer is the largest amount of the tear film, and then the lipid layer. And I shouldn't say it now, but I will point it out that this is actually what is of most interest for the majority of the cases that we are talking about from now on. So the mucin layer, I'm going to talk about the different layers quickly. The mucin layer, that's the deepest layer that is attached to the cornea. And it's very thin, as you see. It's secreted by the goblet cells and by some other structures in the conjunctiva. And it's also the main lacrimal gland, contributes a little bit to that. It contains glycoproteins, some lipids, and it's entered to the cornea by microvilli. And that's important if you imagine that the corneal microvilli are not anatomically there because they're abraded or they're sick, then the whole tear film will just slip away because it's not entered. So the mucin layer will stabilize the tear film, which is in a semi-solid stage, and it's a very hydrated structure. It also lubricates the ocular and palpebral surfaces and reduces friction when the lids open and close. So it protects against abrasive effects by the lids, and if it's not there, the lids will actually rub on the cornea. Then the aqueous layer, the big part, that's the middle layer. It's secreted by the lacrimal gland, as you know, and by the nictitans gland. really thick, and it's a uniform layer. It contains lysozymes, lactoferrins, and the tear-specific prealbumin, and some other proteins as well. It further contains bicarbonate and proteins that give buffering capacities to the tears. And it determines the surface tension of the entire fluid. It provides what we talked before, the atmospheric O2 to the epithelium. And again, it washes away, it has a wash function. And now the lipid layer, the outermost layer, it's very thin again. It's derived from the meibomian glands mainly, and also the other lid margin glands, size and mole. And it contains lipids with different polarity. The low polarities are like wax and cholesterol esters, and as you see in the next slide, there are also polar lipids. It's the fluid layer, it's oily. It contains triglycerides, free fatty acids, phospholipids, and it prevents overflow, of course, but it also reduces the evaporation. And that's actually the main effect clinically that we see currently in qualitative piriform disease. The last point, the last point is really important because it says that the lipid layer is expressed and spread by the lids with the blink. And that says that if you just have a lid sitting there that doesn't move, the meibomian glands will not be expressed properly. So if we think later on about pathologic changes, then this is very important. You need lid function for the lid to be expressed and also to be spread over the cornea with each blink. So this is a graph that shows you the different lipid layers, and then the aqueous layer with all the salt content. And this is the schematic microvilli, and the mucin layer sitting on top of the epithelial cells. The whole thing is actually produced, or it works only if every little component of this so-called lacrimal functional unit is intact. And we start here with the ocular surface and the innervation in the cornea, in the ocular surface and the conjunctiva, and the lacrimal apparatus. So it's not just the lacrimal gland that is producing some watery fluid, and if it's not there, we have a dry eye. It's much more that we have to look at. Very centrally is the neural control, and that's trigeminal nerve fibers in the cornea. As you will see later on, I will focus on that more. And then we also need the efferent parts, that's motor fibers, that contribute to the hydrodynamics of the tears, which means blinking, and as just mentioned, also the expression of the meibomian glands and the tear clearings. And then the other part is the parasympathetic fibers that contribute to the tear composition in the lacrimal gland and the meibomian glands, and that influence the tear secretion. Okay. So the lacrimal functional unit is actually stimulated by mechanical and chemical stimuli. And they evoke measurable tear secretion. So if you place a chemical or a mechanical stimulus on the cornea, you will have a measurable tear secretion. That's important to know. The central corneal mechanical stimulation gives the strongest lacrimation reflex. And if you let that sit and think about it, it really applies to clinical presentation of many diseases. We'll get back to that. The central mechanical corneal stimulation is the major sensory driving force for reflex tear secretion for the entire lacrimal functional unit. So central cornea has a major importance. This is just showing again what we just said. We have the ocular surface, we have the lacrimal gland and the brain, and we have an efferent pathway, which is the trigeminal nerve. and it's shown here in this graph. And you remember that those trigeminal nerve endings sit up into the epithelium, and we have 3 nerve endings right in the epithelial cells. And they receive the stimuli, and then this is transferred to the brain, and you have pain, and you have afferent information to the lacrimal gland, to the meibomian gland, and also to the conjunctival goblet cells. So this is a very amazing system that nature created. And the corneal trigeminal innervation is shown again here. You have very few deep nerve endings and very many very superficial nerve endings, and you know that superficial ulcers some more painful than deep ulcers and so on. So now we are not talking about the ulcers, but about how the nerve stimulation affects the tear function, and also how the tear function affects the nerve endings. And remember that you have these centripetal trigeminal nerves moving into the cornea, and looking at this graph here, down here on the left, you can see that centrally you have the highest, just by anatomical reason, you have the highest concentration of trigeminal nerve endings in the epithelium of the center of the cornea. Then again, this is still how it naturally works, that you have, here is fluorescein placed on the cornea, and you wait without blink, moving from the left to right. And here the fluorescein layer is going to break, and when it breaks, then there is blink induction. And the maximum blink interval tells you when the tear film will be spread evenly over the cornea, and it's going to break, and then the eye blinks. This is how it should work. And in the dog, the blink rate is about 14 seconds. This is just an average. And this is how the natural function of the lacrimal unit works. So then if you have here the lipid layer, and you have breaks in the lipid layer, and you have evaporation, what happens is that you have spots where no tear film is. And this is what we just saw, and I just go back what we saw, what happens naturally before you blink. Then if you have a diseased lipid layer and you get those dry spots, what happens is that your trigeminal nerves are going to be stimulated, and you get reflex tearing. But also, if this is continuing, you get reflex uveitis. And if you watch closely, you will see lots of ocular surface disease patients that have, like chronic ocular surface disease patients that have reflex uveitis. And that contributes to ocular health in general. And of course, you have pain, and that is bad. That is quality of life. So tear film quality actually guarantees quality of life, and we're going to talk about this later. The other thing is, if you have an irregular thickness of the precorneal tear film, you will also have a blurred vision. And this is why it's of interest for many cataract surgeons. It became of interest in the last couple of years that they would do the more refined techniques and the smaller incisions, and also and still the patients would complain about blurred vision after surgery. They were not satisfied. And this is because not much care was taken about the tear film. And I'll try to open your eyes for that during this webinar. There's numerous papers out there that if you don't blink enough, or if your tear film isn't good enough, your retinal image quality will be compromised. And look at this number; it's quite dramatic. If you look at a drop of visual acuity of 0.3 diopters, if you hold your eyes open for 10 seconds. So if you hold your eyes open during the seminar, you will be blind at the end. So dry eye causes blurred vision, bad quality of vision, and we should also consider this in our patients. So number of stimuli or noxious stimuli from inflammation, environmental, tear osmolarity, surgery, all that could influence and cause nociceptive pain. And either this can all be resolved and you have transient dry eye symptoms, as we will see later in the cases, like after you have an ulcer. Again, sorry. If you have an ulcer and this ulcer has healed, then your transient, maybe your transient dry eye symptoms are gone. And but when you have scenario B and you have ongoing inflammation or an ongoing insult or genetic disability, you have the chronic dry eye syndrome. So what kind of dry eyes do we know? We know the aqueous insufficiency, that's a classic dry eye, where you have, sorry, where you have, I'm moving my hands too much, hyperosmolarity of the tears in people, and we're going to talk about that in a second. And you have various situations that can cause aqueous insufficiency. I'll walk you through a scheme in just the next slide. And then we have this group of evaporative dry eye that is more difficult to diagnose, and this is why we actually talk about the ocular surface analysis. So this looks like a little bit busy, but I would like to show it to you because it gives you a scheme how to think about dry eye. And the first thing is we're going on this aqueous deficient dry eye part. And this is human, and I circled what we have in the dog. Aqueous deficient patients are the ones that have low Schirmer tear tests, and they have crusty eyes, and they have lots of mucus discharge. So the classic dry eye that we used to talk about, KCS, for years. In people, we have Sjogren's syndrome, and in animals, I think we also have immune-mediated dry eye. And then we have non-immune mediated dry eyes with electromal deficiency. If you are if you're like a Vesti, or if you just have other sources of electromal deficiency, and your aqueous layer will be reduced. And also some systemic drugs, remember all the sulfa drugs, can cause a drop in the aqueous tear production, and can leave you with this part of dry eye. And then the second part, which is actually the one that we see currently more number-wise, is the evaporative tear dry eye. And here you can see disorders of the lid aperture. That's something that affects us a lot. Low Brinkley rate and the meibomian oil deficiency, meibomian gland disease. And if you look here at the topical drug application with preservatives, we see that some drugs are not tolerated well and they cause evaporative tear film disease. Or here, big thing is the allergy. The allergy can cause evaporative tear film disease. So just to give you the scheme, this overview, if you have healthy tears, you get lots of good things in there. We talked about the different ingredients. And then if you move to dysfunctional tears, you have an increase in unwished, unwanted ingredients in the tears. And not only have you a decreased concentration of antibacterial proteins, a decreased concentration of soluble mucins, but also what I think is what you have to take into account, we have an increased protease activity that will work on the extracellular matrix and will work on the epithelial tight junctions and cause alterations there. And that leaves you more imagination why, for example, brachycephalics get central ulcerations without any cause. The increased tear osmolarity, again, is mentioned here. We don't really take too much focus on that in animals yet. And I'll show you why. So when you have this altered tear accumulation and you have a depletion of protective factors, the bad thing is that they also accumulate here at the lower lid, and you have then a high concentration of inflammatory factors right there. This picture shows a human patient where the altered tears have actually caused some damage, and there's Bengal rose staining in the area where the toxic altered tears sit and make damage to cornea and conjunctiva. So I think this is one of the last schemes that I'm showing you, but I think if you do this together, you will get an insight or a review. Yeah, centrally with the tear film instability. And then this is going to cause hyperosmolarity, which means you have more ingredients that you don't want in the tears. And that causes cell damage and apoptosis. And that again stimulates the nerves, the corneal and conjunctival nerves, and that promotes inflammation and a lot of cytokine release, which causes goblet cell loss. You know, the mucin layer is going to be damaged as well, and that will lead to more tear film instability. And there are all kinds of different, this is human again, all kinds of different diseases that can contribute to the alteration. Just look at the autoimmune diseases or look at the blepharitis. We see that in dogs all the time and in cats. Big thing, allergies, I mentioned that before, environment. Viral conjunctivitis, the cats. So all that can lead to tear film instability. And look at the golden circle in the center. Here is the meibomian gland dysfunction. And that only in the meibomian gland dysfunction can start the whole circle. So if we are not able to get out of this vicious circle, this will be more and more inflammatory, and we will have corneal changes, and we can have vision disturbing disease. Dry eye in people affects about up to 50 to 70% of the population. Think about it, 70% of the population, 7 out of 10 sitting in front of your computer now have dry eye. And it's an increasing incidence in the ages of 18 to 34. 90% of those patients don't have dry eye, classic dry eye, aqueous deficient, but deficient lipid layer. So this would be evaporative tear disease. Meibomian gland dysfunction will be the major thing in people. And the most common causes in people, again, look at the first course, that's lifestyle, digital era. That's exactly what we're doing now. You're staring at your computer, or maybe you're not, but you're staring at your smartphone, you're staring at the TV, and this impedes with your blink rate. And the screen time is increasing all the time. And if you have incomplete blinks because you're so staring at your computer, then you might get evaporative dry eye. It's induced, and then you start the whole circle, and you know what happens. I think we also see that in dogs, and I think every one of these causes that are listed here, we have that in dogs and cats as well, in our animals. So topical and systemic medications, allergies, blepharitis, external factors. Animals have even worse external factors because they live below and they have air condition and wind and dust and I don't know what. We have surgeries, of course, that interfere with the tear film. We have the hypothyroid dog, the diabetes, very common. Neural dysfunction, older animals, immune-mediated diseases, diet, sleep disturbance, I don't know if it counts. However, I just want to show that there are lots of contributing factors to cause evaporative tear film disease that will also be there for our animals. The subjective sensations that the patients, the human patients, talk about is chronic irritation, pain, rubbing, burning sensation, tired eyes. They want to sleep, they want to close their lids, and they can concentrate, and they have a foreign body sensation. They will say, it feels like the sand is in my eye. And we have all that in our animals, they just don't tell us. So I think it's definitely an impact on quality of life. And if you're successfully treating an animal that has qualitative tear film disease and you have a sensible owner, they will tell you that the aspect and the whole attitude of the animal changes. So coming now to the more clinical stuff, remember that it's mandatory for a healthy tear film to have this blink mechanism, and you need the complete blink. And you need a smooth and even corneal surface and a smooth lid margin. And all that, there's so many diseases that interfere with this mandatory for a healthy tear film. And I included here a brachycephalic dog where you can actually imagine that this blink is incomplete in this dog and this is left open. And here is, remember all the stories that we talked about, just the central cornea being the most innervated, most important part for the lacrimal functional unit. And there will be a lot of activity, and this is the least covered area in many eyes. So sometimes we even have distichia or anything else interfering at the lid margin. So many things that can contribute to development of evaporative tear film disease in our animals. And if you, hopefully after the webinar, if not before, you will look at this lid scar. That's a less than satisfactory adapted lid margin after a cut or surgery, whatever. And this is rubbing on the cornea. That would be one aspect. We could say this is mechanically disturbing the epithelium. But we can also think about what we just heard, and this is disturbing the tear film. And just by disturbing the tear film in this area, you will start the whole vicious circle. And then we have an ulceration and we have problems. So think about the two ways that causes a scar like that. Also, the very common lid tumors that cause rubbing on the corneal surface just mechanically on the epithelium, but also by disturbing the tear film and the blink and all the spreading of a healthy tear film. That does not happen if you have something like that here. And many times you will see this lucky slimy discharge in those dogs. And it's not just because this is mechanically disturbing, but because the tear film is unhealthy. And this would be in the group, remember the scheme that I showed you, where when you take away the noxious stimulus, then it will take some time, but in the end you will recover completely, or you could recover completely if you excluded all the factors contributing here. And this is a very good chance that this could effectively be treated. So if you have, this is another scheme where you have the healthy tear film with the lipid layer, the aqueous layer, the mucin layer, and the epithelial cells. And the lipid layer is deficient, and you have those breaks, a dry spot, pain, reflex tearing, epiphora, blurred vision, keratitis. And then what comes in is that the reflex tears with a lower concentration of proteins and mucoproteins and all the stuff that is in there, they will even wash away this poor leftover tears. So with the reparation mechanism, you make further damage. And you can see those breaks, those dry spots, if you disperse fluorescein on a cornea of a brachycephalic dog, you will very soon see those lakes, those breaks. And if you watch at a very high magnification, you can see those spots show up in blue light. How does this apply to our patients? We see lots and lots and lots of Frenchies, and more Frenchies every day. And you know that the French Bulldog outnumbered the Labrador in Great Britain. In 2018, there were more French Bulldogs registered than any other breed. And for us in our clinic in 2019, we had 9% Frenchies of all new patients. And in 2020, we are now about 10%. And it seems like some days we just have Frenchies, or every other patient is a Frenchie. And if I had this poster at ECO last year, and just to make you aware of how important this ocular surface disease is, and to give you some numbers, the most common diseases that we saw in this roughly 800 dogs that we reviewed were ocular surface diseases. So it is important to look at the ocular surface. with the keratitis and the tear film disease being the most important ones, most common ones. It's not just the Frenchies, we also have lots and lots and lots of pugs. And you know that pugs, I'm just presenting this because it's an entity that is known by everybody, that they have this pigmentary keratitis, and in the majority of their dogs, even not presented as eye patients, they will have about 80% of pigmentary keratitis. And the ocular surface disease in pugs has been shown to be of inflammatory origin, and contributing factors are probably macroblepharon, nasal entropion, lack of thalamus, and qualitative KCS. This may be worsened by those contributing factors, but it might be a primary problem as well. And I want to show you this just to show you there's lots and lots of clinical implications for ocular surface analysis. If you look at the brachycephalic breeds, you can see that hairs and stuff is laying in the center of the cornea. Again, this is the area most important for the electromal functional unit, and it makes perfect sense that this eye will have a chronic inflammatory response. Lack of thalamus, be it a Shih Tzu or any other breed with prominent eyes, they have problems. And you can see here in this slimy eye or the tear film deficient pug that this is obvious ocular surface disease. So again, you saw that graph. We're going to check for the lipid layer. We're going to check for those breaks. It's very simple to get the aqueous layer checked, you know that, and the mucin layer is difficult as well. So focusing on the central cornea, like you saw here, the ulceration that occurs in many dogs centrally is not just a mechanic factor, but it can also be the result of a chronic deficient tear film. So this is no wonder that we see ulceration centrally. This is also the center because this dog has a lateral strabismus. And now we're going to move on. How can we prevent those ahead of the time and look at the ocular surface before the disease progress moves on? The constant irritation is there, chronic inflammation is there. In dogs, all dogs will have chronic pigmentary keratitis, not only pugs, but also any other chronic inflammatory corneal disease. And we have stromal fibrosis, and we have reduction of vision or loss of vision in the end. So typically in those dogs, clinically, with suspicious evaporative tear film disease, that's called EDE, what will we have? We will have Schirmer tear tests in the normal range or high. We will have, if we watch closely, the characteristic slimy discharge. And that's not just the brachycephalics. If you remember the dog that I just showed you with the upper lid, meibomian gland adenoma, probably also had the slimy discharge. That's the slimy thing. And we suspect meibomian gland dysfunction, and maybe that's a compensatory goblet cell reaction. We don't know. So that's what I could imagine, that the goblet cells overreact. So this is the clinical presentation of a dog that is suspected qualitative tear film disease. So now let's move on. We talked about how the tear film is, how the tear film presents, the different layers, the functions, the contents, and we are now moving on to the examination. And we would love to have a look at the different layers, not just the guess that this dog has evaporative tear film disease. I tried to guide you to the idea that this is evaporative tear film disease, but we would rather want to have a specified examination technique. So what can we do if we want to look at tear quantity? When we look at the aqueous layer, what diagnostic tests apply? What did we do in the past when we thought that the dog would have KCS? We would do a Schirmer tear test. Schirmer tear test 1 is the typical clinical diagnostic tool for dry eye, classic dry eyes. We could also measure the amount of tears that are sitting in the area between lid and cornea. And I'm going to talk about the tear meniscus later. And I mentioned the osmolarity. That is also one of the tools in human ophthalmology for dry eye. If we want to look at the oily and mucus layer, we can look at the tear breakup time, and I'll go over this in a second. And we can also do vital staining. We all do that all the time. And we could do a specified lipid layer assessment, and we could look at the meibomian glands. So if we look at the classic diagnostics, we have the slit lamp, we have Schirmer test 1, we have vital stains, we have the tear breakup time, and we can evaluate the meibomian glands just by watching them, by looking at them, by looking at the openings, and by expressing a little bit of the secretion and checking the secretion, the characteristics. So the Schirmer tear test 1, you know, it should be over 15 millimeters in 1 minute. That would be the norm. And we have those Schirmer tear test stripes that we use, and it measures only the aqueous part of the tear film, the aqueous layer, and we are fine with that. So if the Schirmer tear test is below 15, we would say suspicious for KCS, classic dry eye. If it's normal or in the 20s, what we would expect in a young normal dog, we should say, so everything is fine. Then we move on and do the fluorescent test and the tear film breakup time. And that is placing a drop on fluorescent on the eye and closing the lids, opening them again and checking. And this is the different grades that we have. That's almost non-staining. And here you have a little bit of staining. Here you have lakes and breaks. And here you have an ulcer. However, if you see one of those mucin strands or agglomerations, you can already think about qualitative tear film disease. We mentioned that. And there's a relatively new publication from a group around Gustavo Aguirre that showed that lissamine green, which is widely used in human ophthalmology, can be used as an indicator for dry eye when there was a higher staining grade associated with a low Schirmer tear test and a rapid tear film breakup time in the dogs that they had in their study. So it could be a good adjunctive test. You could use it as another vital stain if you think about the dog having KCS. The tear film breakup time has been described by the Japanese colleague Saito and by other colleagues as well. I mentioned these because I wanted to show you that the results by placing a drop here, closing the lids, opening the lids, and counting the seconds till you see the first break with the slit lamp. That's the tear film breakup time. Has highly variable results. And if you see here, that's 24 seconds plus minus 8. So it's very difficult to use this as a clinical tool to decide whether this dog has evaporative tear film disease or not. What you check for are those breaks in the fluorescent dye, and you can see those with high magnification and blue light. You can highlight them with your slit lamp. And we talked about the meibomian glands, the clinical exam where you actually look at the openings here, and you can see that they are blocked, they are kind of gross. And if you put a forceps here, which could be like the suturing forceps, and you apply a little bit of pressure from the outer and inner part in the lids without damaging or putting too much pressure, you can express a little bit of secretion, and that should be soft and oily and of no color or a little bit yellowish, but it should definitely not look like this one that is sticky and looks greasy and not nice. So that would give you, again, a clinical indication that something is wrong with the meibomian glands. So the tear osmolarity, that's what I mentioned several times already, is a tool that is used in human ophthalmology as a diagnostic, and also some colleagues are mentioning it, and there are contradictory papers that make it hard to use it as at this very moment as one tool for diagnostic of dry eye, especially for evaporative dry eye. Just to show you what it is, the tear Ferning test is an indirect determination of tear osmolarity, which means that it collects tears and place it on a glass slide and let it dry, and the way those crystals are formed is graded, and then you can see in the left a normal Ferning test, and in the right a Ferning test with a suspicion of a tear film disorder. And there are also devices that you can use, and you can measure the osmolarity. However, this new publication of Lamkin again states that there are highly variable results, and the clinical impacts to date unclear. So that's, I think, not something that you can use at this point. Contradictory is because Williams also had the tear Ferning test as topic of his paper in 2017 published. And he claimed that in a grading system, 4 grades, and he claimed that it's a good tool to measure or to as an indication for KCS. Another paper used a computerized scheme to avoid more inter-examiner variations, or to more objectivize the whole test. However, the latest publication again states that there is not much difference in the Ferning test between basal normal tears and stimulated tears. So at this very moment, I wouldn't encourage you to use the Ferning test as an indicator for dry eye. This might change, and this is just an update on what is. For me, it's just a point in time, and maybe this is an area that is quickly evolving, and there's so many people working on it, which I think is great, because 10 years ago nobody would look at the qualitative tear film, almost nobody in veterinary medicine. So I think that's great, but also leaves us in a movement. We have to look what comes up. So this is why we're actually gathering, because we're going to look for more refined ways to look at the tear film, especially for those, and I tried to show you how many patients we have, not just we, but how many patients are there out with evaporative tear film disease. And this is an instrument, and it's actually almost a camera with a very good software that is called the Ocular Surface Analyzer, and that allows the more specific examination of the tear film. This is the way I would put it. You can look at the lipid layer with something that is called interferometry, and I'll go over that step by step. And you can look at the tear film stability by a non-invasive tear breakup time. And we just talked about the tear breakup time with placing a fluorescent drop, and that's obviously quite examiner related, and it has those high variations that leaves you with, what do I do with this now? How can I justify to put this dog on a drop, or how can I place my diagnosis? So this is a non-invasive tear breakup time, and it might be more objective than what we do with the classic tear breakup time measurement. You can quantify the aqueous layer with the tear meniscus height, and you can examine the distribution and the size of the meibomian glands, and that's called meibography. And you can also measure the blink frequency and the blink quality, if it's complete or incomplete. And you can look at the topography of the cornea. And this is all one thing in a very quick exam. You do this in an awake animal before you do anything else. So before you do your Schwimmers and before you place any dye on any staining on the cornea. And it's a really quick exam. I told you that we're going step by step through the different examinations, and we'll start with the interferometry. That was the examination of the lipid layer. And what you get is the camera with the light is directed towards the cornea, and it will reflect the light in a certain pattern. And on the right, you can see that the light will be broken by the different layers, and then you get reflected an image back that will have like a marmorized or oily aspect, and this is actually what you want. That's the lipid layer that is dispersed on the aqueous layer. So that's actually a qualitative and quantitative. It measures the thickness, or it shows you the thickness, and it determines the thickness. And it also tells you how the lipid layer, the quality, how it is dispersed. And so you get different reflections. On the right is the one that we just saw. That's the one that you want. And that tells you how thick it is. That's the ideal interferometry picture. That's less ideal, where you have just some strands here and it's less thick. And this is something that you wouldn't want to see in a normal animal. That's kind of a pale white disc, homogeneous. There's no marmorizing, no oily layer on top of it, and it's very thin. So you can use comparison pictures and thereby measure the lipid layer thickness. For the non-invasive tear breakup time, you can project, or that's what the camera does, project a light with rings onto the cornea, and then you see the stability and the integrity of the tear film when you see the first breaks. And you can see here that you see those round placido rings, and you see the straight areas here. And once those rings break, this is when the tear breakup time starts. So the instrument actually, or the software, measures the time between evenly placed placido rings and the first break. And that gives you an information on the stability of the tear film, and also indirectly on the mucin layer. So you measure the time until you see the first break. And that's the non-invasive breakup time. You don't need to use the fluorescent that we talked about using just a seconds before. And here you have some pictures with the placido rings intact, and here you see the break, the first breaks, and here you see a completely irregular picture. If you have a classic dry eye, and that's like an aqueous deficient dry eye, you would get pictures like below. You wouldn't be able to place regular placido rings on an eye that is completely dry. You can also have an automized break picture where you can see where the first breaks occur, and then it is indicated what your breakup time actually is. The tear meniscus, that's something that is quickly done in the same exam, that you actually measure the area where the water accumulates between the lower lid and the cornea. You can measure the meniscus, tear meniscus height in millimeters. And then the meibography is the examination of the meibomian glands with infrared light. So again, it's a camera that is doing this. And then you can see those meibomian glands, it visualizes them, and you can evaluate the structure and size, and can compare those to schemes, to scales that are inserted in the software. So we have quantifiable results. And here's some pictures. This would be a very nice lid with normal meibomian glands. You can see the openings, and the infrared gives you this picture. Here you can see that there's a little blockage, that this is less even. It's like inspissated and thick, and here is a space where a meibomian gland is maybe missing, or it's not filled. You can also, there's a feature that you can have in the software that shows you a three-dimensional view of single meibomian glands. Here are more examples. You can see those blocked ducts. You can see accumulations and dropouts of entire meibomian glands. They don't do anything, they just sit there, and they are maybe blocked too long and they have atrophied. And you can see that here different types of secretion is sitting in the meibomian glands. So this is the type of picture that you would get. You can of course see distichiasis there, and you can see other types of irregularities from the inside of the lid margin. You actually just invert the lid with your thumb or with a Q-tip, with a cotton tip applicator, and you roll it out, and then you can take the image. So now we're moving on. I showed you the ocular surface analyzer, and then I would like to make a short comment on what we can do with the results. How can we treat evaporative tear film disease or dry eye, classic dry eye? And then we're going to move on to some cases. My point is, with ocular surface disease, don't treat the effect. Don't put just drops, tear replacement drops on, or don't put just steroids on the inflammatory response, but determine the reason, determine the cause. And I think the more refined examination techniques we have, the more detail we can look at the tear film, the better it is. The more detailed our therapy can be. So in general, the ocular surface disease is really complex. There's so many components. I tried to bring that to your mind. So many components influencing ocular surface disease. And it's typically a chronic problem. And if you have chronic ocular surface disease or chronic evaporative dry eye, there's no cure. It's not something that you can heal quickly. And there's no therapy, or almost no therapy, that is directed to the primary reason. Oftentimes that's impossible to treat. There's no golden therapy, no golden drop that helps all the different types. And it's always lengthy, so patience is needed not only by the patient, the dog, but also by the owner and also by the veterinarian, who often is very impatient and wants to see a result right away. And another point is that in most of the types of dry eye that is not the classic dry eye, and also in that, the effect of the treatment will only last as long as you treat. This says that if you start treating, the classic dry eye, you start cyclosporin, and the owner is non-compliant and will stop it when it gets better, you will typically fall back to the primary picture. So, and that's difficult. If you treat and it gets better, and for the owner, the understanding that you have to treat lifelong is oftentimes very traumatic. And that is influenced obviously by the compliance of the owner. So current treatment concepts eliminate all those mechanical factors if you can. You're lucky if you have something that you can eliminate. So if you can work on the lids and improve the situation, you're lucky. If you can improve the environmental factors like increasing humidity or decreasing dust and pollen and stuff like that, you're lucky as well. Then you can apply medical therapy, and we're going to talk about this in a second. You can use anti-inflammatory medications, lacrimogenic or lacrimomimetic drops or ointments. You can use essential fatty acids in your diet, and you can clean the margins with different devices. I'll show you this one. You can unblock the meibomian gland ducts on a regular basis or just once, depending on what is needed. You can use heat and massage. It's very intensively used in human ophthalmology, and we do that also, or we recommend it in dogs. So there's more to come. So getting back to the mechanic factors, if you're lucky and you have those lid tumors here, you can take them out. If you have the brachycephalics, you can shorten the lid fissure, and you know that you have excellent results with this. Adding cyclosporin, you have very good results. So the current medical therapy in general for ocular surface disease would be cyclosporin as ointment, drops, implants, tacrolimus steroids, hyaluronic, that's hyaluronic acid, hyaluronic acid, methyl cellulose, polyvinyl alcohol, Carbomeris, whatever covers the cornea longer or less long. You can replace lipids topically. You can use petrolatum. You can use this, and I'll show you this in a case later. That's a drop that we have in Germany. I don't know about the international situation. Thymosin beta 4 was a big thing, or is a big thing in human medicine. It's extremely expensive, but it worked in some patients for us. You can use serum, autolog serum. You may use antibiotics in some blepharitis cases. Azithromycin has been used for meibomian gland disease. And again, the essential fatty acids orally. That's a cyclosporin implant just prior to implantation. And in general, there's not the one ideal drop, you know that. There's so many, just by the lacrimal mimetic drops, there's a myriad of products that you can buy on the market. So there's not one thing that you use on all different parts. In general, if you use drops or ointments, the more viscous they are, the better they are. They blur the vision, but usually we're not that sensitive in dogs than in people. You should always use preservative-free drops. And you should remember that the tolerance is different individually. And that's why it's quite drastic, that some dogs will just not tolerate, for example, cyclosporin drops or cyclosporin ointment or tacrolimus drops or ointment. So you have to be prepared that you will worsen the situation initially, and you have to change the topical medication. But there's so much on the market that you can choose from. It's just difficult to keep the owner on track. If the situation worsens initially, then it's difficult to get the owner back to try another drug. Anti-inflammatory drops, initially short-term steroids. Remember the circle, you have a lot of inflammatory response. We do that quite often on a regular basis, that we add anti-inflammatory drops initially. I mentioned serum. Okay, so now we are moving on to some cases. Whenever you have questions, I forgot to mention this, this is like a terrible monologue. Whenever you have questions, you can type them and Richard will forward them to me and I can interrupt, or we can talk about this later at the end. If not, I will just move on to the cases. This is the ocular surface analyzer in place, and actually if you're used to the system and you have everything set up and ready, it's a quick exam. In people, they call it the 4-minute exam. So you can actually do it in a few minutes and you get an information, as I showed you, very refined information about the tear film layers. So this is my first case. It's a 12-year-old Sighthound, the Prudenko, and he has been blinking a lot. Actually, the owners have seen him just like blepharospastic, small eyes. He has never open eyes. He doesn't seem to be relaxed, and he has a lot of tearing. And he has been treated with topical steroids with no improvement. This is when they show up, and you can see the clinical aspect. The presentation is this like a little bit swollen lids. You can see here some yellow stuff. And you can see that the eyes are not open. You can also see that the Nyctotan's margin is depigmented, and the cornea, there's lots of tears in here. You could also think about the tear meniscus height just by the picture. So the eyes are full of tears, and the cornea is shining. The reflex is really good. We look at the meibography pictures that I included here, and you can see the duct openings, they are all blocked. You can see like little blocks here, and you can see the inspissated meibomian glands, where the secretion is just sitting and it's not coming out. And it will form some agglomeration here, and here is a dropout of an entire gland. So we would call this a blockage of the meibomian glands, or meibomitis. And we would use, I told you about the forceps that we use delicately, and we would try to express some of this to see how the secretion is. Is it really thick, or is it oily and nice, and does it come out easily, or is it difficult to express? And you could see here what came out of the meibomian glands. It's a hard, waxy, terrible secretion that comes out of every meibomian gland opening, and that's actually the blockage here. And the secretion is really thick and not normal. So this is his problem. And this is when you can clean the lid margin. That's an instrument that there are many of on the market that you can clean the lid margin with. It works like an electronic toothbrush, and you very delicately clean the blocked meibomian gland openings. And this obviously has to be repeated depending on if they are inspissated again. This has to be repeated at several weeks or several months. Sometimes we just use this once and then never again. You do this under topical anesthesia and very gently clean the lid margin. In the Podenco, we also recommended warm compresses. I recommend this quite often because it helps to reduce inflammation, to make the secretion of the meibomian glands more soft, to enhance the secretion, and also enhance the blood flow in the area. So you need something that is hot or warm and tolerated well. And you can use warm, dry compresses, or you can also use wet cloth if the owner prefers that. The point is compliance, because you need to do this on a regular basis, once daily or at least 3 times a week. And that's the same in people. They have to do this. And there are several instruments in people where you can massage out the meibomian glands, but they are not really applicable in dogs. So I think warm compresses, heat, topical heat is better if you use that than try any instrument. This dog would learn to tolerate his mask, and when they were watching TV at night, he would just lay there and have his mask on. So that's something that we use a lot. After careful cleaning, we use warm compresses. In this case, where you have those blocked ducts and you have accumulations, you could also use acid or azithromycin topically or systemically. We have in Germany, we have eye drops, and you also have a liquid that is for oral application. We use tacrolimus in this specific dog topically, and we use steroids if needed. So this is a lifelong therapy, lifelong warm compresses. He will never heal. Once the owner notices that he is recovering so well from this initial more intense treatment, and he's so much better and he opens the eyes, they are on track. They do this on their own, and we see the dog twice a year or 3 times in 2 years. So that's something the owner has to take over, and you have to build up the understanding, and you have to build up the compliance or enhance the compliance. Other treatment options for completely blocked or not working meibomian glands is to stimulate those glands. And you can, of course, use tacrolimus to reduce the inflammation and stimulate. It will work a little bit on the stimulation, but you could also try this stimulation from the nerval aspect. And this is the intensive pulse light, and it's quite a game changer in people for meibomian gland dysfunction. And we use it in dogs, and I think it's a really. Oh, Richard has a question. He's waving there.
Yes, yes, Ingrid. There's two questions. The first one from Lee Sluninsky. What is the underlying cause in Podenko's case? Could this be leishmaniosis?
Oh, it
And
could,
what is
well be. This specific dog is leishmaniosis negative, but it could be he doesn't have any other inflammatory blepharitis, inflammatory response, and it's a genuine meibomian gland disorder. I'll show you another case where it happens and there's no underlying disorder, like you could point to that. Allergies may play a role in the initial state, but once when we saw him, he was so chronically affected, and we treat the meibomian gland inspisation, or we try to enhance the efflux of the secretion, and he's so much better. So there's no way we could point at the initial noxious stimulus.
And there are two additional questions, both from Liga Kovalkuka.
You said that very well.
Oh, thanks. She said, thank you for the lecture, of course. And how can errors be avoided in interferometry by holding the animal's eye open or making, if you can cause too much pressure on the lids? I think I have that question right. Mm-hmm. Yes.
I think like there's a little learning curve, but it's really steep. You don't need to, there's not a lot of practice involved. I think the practice is more to get used to the software and to like click through the system. No, we usually do it with two people, one holding the animal, as I showed you on the picture, one holding the animal to keep the animal calm, and that could be the owner or a second technician, and the other one holding the camera. And you just close the eyelids and open them up, and there's no, I don't think there's there's no technical error that should be avoided. No, it's simple.
Okay, and then her second part of her question, is there a reference for, or do you have any references for meniscometry?
There's not much data. It's like in people, there's lots of reference. In animals, no. Just think about how long we are using the analyzer or analyzers in general. It's an evaluation, but think about again, what we typically do is we run the sequence and like the whole thing, interferometry, micrography, tear breakup time, and meniscal height, blink, and then at the end we do the Schirmers. And we are used to evaluating Schirmer tear tests, and that gives you the aqueous layer quantification.
Okay, and then there's another question from Dr. Jack, and asked that about doing culture and sensitivity for meibomian gland secretion disorders. Do you usually do that routinely in these cases?
On those cases like the Podenko, we might consider it, but if we have like the typical evaporative tear film disease where you don't have those inspissated meibomian glands that I started out with at the first case, you usually don't have this kind of secretion. You have a lower function and not enough lipid secreted. So we try to stimulate them, but it's not like we would have bacteria sitting in there. In people, they have mites sitting in there. That's a big problem. And the azithromycin idea is not just because we are treating it as an antibiotic, but it itself has an effect on the meibomian gland secretion. That's why we're using it. but you could always do a sensitivity, cultural sensitivity, if you have the idea that this specific patient would have any bacterial involvement. Not as a routine. No, I wouldn't say we do that as a routine. Okay.
And that, for the moment, that's it.
Okay. So here you can see those pictures of the intensive pulsed light, and this is something that has no reference at all. I just wanted to bring it in here because I think if we are left, I'm going back one slide, we're left with a non-functioning or dysfunctioning meibomian gland, and we have few ways that we could stimulate this meibomian gland, and it contributes to such an important structure of the tear film. And we have the possibility to stimulate this novel supply. It would be good to do it. And we looked at a series of dogs and we had quite impressive results. So I just wanted to bring this up to you, also in people. Obviously, this is something that with very individual responses, but the majority of the cases responds well to that. Then we have another case that's a Tibetan Spaniel. It's 9 years old and it had a prolapse, globe prolapse on this left eye 3 months ago. It was repositioned. It's still in there. It has a chronic keratitis, and I just wanted to show you the also findings of the corneal topography. And this is when you place the placido rings on the right side, you can see that they are evenly distributed and nice and round. So we're not talking about the tear breakup time at the moment, which is also reduced in this case, but we are talking about the topography, and you can see the distortion. And you can imagine that the problem is for this keratitis that the dog has a ruptured medial rectus, or a lesion medial rectus, and thereby strabismus, divergent strabismus, that causes the cornea to be exposed and change of topography. The Schirmer tear test was really high in this eye, and you can understand this from what I said because it's a compensatory stimulus. So what we did in this case, we did a surgical correction of the nasal canthus, so a canthoplasty, and we used oily ointment, and that helped him quite a bit. And this calmed down. So this is a French, yep. Richard is waving.
Yeah, we have another question, Ingrid. This one is from Kasturi Batsavle. Is there any particular reason why azithromycin is preferred over doxycycline for meibomitis?
No, it's just that doxycycline in Germany doesn't exist as a topical medication, and I would rather treat an animal topically if possible. But you could use doxycycline for, we use it a lot for blepharitis, like severe blepharitis cases. No, it's just not available topically in Germany. Okay. So this is a 7-year-old French bulldog that had a non-healing ulceration. And this is the situation after it healed. And actually I have to commend that we see much more horrible corneas after SCEDs in Frenchies, which seems to be an entity that totally puzzles me. But this has healed with this reaction. And if you now look at the tear breakup time in his right eye, you can see it's 6.4 seconds. And in his left eye, you can see it's 3.9. So it's severely short and shortened by the topography of the cornea, because in this area, the cornea thickened, there's an inflammatory response, there's an ingrowth of vessels, and thereby the whole topography is changed. To start with, we have a low tear breakup time. Remember that I mentioned that the average blink reflex is 14 seconds in the dog, and we have a tear breakup time of 6.4 and 3.9. So this dog must sense terrible pain in his eyes because it's dry. So we use tacrolimus topically and hyaluronic acid. This is a dachshund, 8-year-old, who had cryosurgery 6 years before because he had severe distichiasis. This was with another veterinarian. I can comment that I don't like the cryosurgery, but I know that many people like it. And usually it's claimed that the pigmentation comes back. This is just an aesthetic thing. It's not important, but in this case and in several cases that we see, it never came back. And maybe just to tell you in advance, maybe this was overdone. Maybe there was used too much cryo. I don't know. I haven't been there at the time of the surgery. I can just tell you that this dog had cryosurgery for distichiasis 6 years before. And now he's presented because he has constantly irritated eyes. He's tearing, and you can see that the epiphora runs down very, very far. And he doesn't look very happy. He has closed, semi-closed eyes, and he's tearing and rubbing and irritated. And this is how the lids look. And you can see that already now you can see that there's like black areas when you fold out the lower lid. And you can obviously see the conjunctivitis, the conjunctival folding, the redness. The Schirmers are high. In the right eye, we have 30 millimeters, in the left eye, 25. So the eyes are indeed red. And now we fold out the lids, and you can see those black areas with, I would say, almost no meibomian gland opening. And again, you can see the bulbar conjunctiva is severely inflamed. And these are the pictures of the meibography. And you can see, I'll try to read them for you. You can see the meibomian gland dropouts in a quite, on this eye, you can see quite an intensive area where there are no meibomian glands at all. And the other ones are inspissated or blocked. And there's a lot of secretion in here. And below you can see the interferometry, and you can see that this is a white disc. There's no oily layer on top of it, no marmorization. And you get by the software of this very instrument. In this case, you get such a chart, a record that shows you where you are, and there are those little darts that show you red is bad, yellow is better, green is good. That's quite basic, but you can also see the numbers, and you can see here the Neibud, you can see the interferometry that's in the lower scale. We saw the 3 grades to start off, and we saw that there is a white sheet, there's no oil, so it's bad. And we saw the changes in the meibomian glands. And we placed this drug on top of the eye. And that's something that is quite amazing. It exists in Germany. I don't know, definitely difficult to get it in the States, but I don't know about the rest of the world. Just wanted to share. We used those drops, and I'll tell you how they work. And we also used an oily ointment, and I'm stating oily ointment because I don't think it makes a big change if you use more vitamin A ointment or more dexpanthenol ointment. Remember that some ointments with the same ingredient, just by the way they are done, are not tolerated. So there's a lot of individual intolerance in those dogs, in those patients, cats as well. So this is the drug. It looks watery, but it's actually oil. And it comes with essential fatty acids along. And this is what the company shows. This is a physiologic tear, how if you place it on a superficial, like whatever, you have this tension. And if you have a meibomian gland deficit, tear, it will just spread out, it's watery, it will just float away and not remain on the superficial area. And then if you place this drop, it will just coat the tears and will trap it kind of onto the cornea. And if you place, the recommendation is once or twice daily, you place it on a meibomian gland deficient eye, it will really make a nice coat on top of the cornea. And many patients tolerate it very well. If you don't have it, I would still use an oily ointment and hyaluronic acid in combination, because this is what's missing. And we can't get those destroyed meibomian glands back to work. There's no way. So this dog has to live with it, and we can alleviate the signs. So now we have this pug, it's 6 years old. It had canthoplasty, like most of the dogs that come to my place. 4 years ago already, and he was on cyclosporin twice daily since then. The owner was quite happy with the result. This is prior to surgery. This is the situation now. Dog's gotten older. And you see the nasal canthoplasty, typically rounded canthus. And you can see here the eye. And she came in because she had irritated eyes for some weeks. Even though nothing has changed, cyclosporin was given and everything. So Schirmer tear tests were high, 28 in the right eye and 32 in the left. And looking at the meibomian glands, we had the impression that the secretion was blocked there. Fluorescent test was negative. There was a little strand of mucin here, maybe some hairs or whatever involved there. So we did the exam and we looked at the meibomian glands, and they were indeed blocked, and some had dropouts, which means that they are not working. There's no secretion there. So we cleaned the lid margin, and you don't actually need, just a second, you don't need this specific instrument. You could also use a gauze and moisten it with some disinfectant and then swipe it over the lid margin and mechanically clean the meibomian gland openings. Richard?
So there's another question that came in from Antonio P. What's your favorite treatment for distichiasis if not cryosurgery?
Oh, I use the in-block resection all the time, which means that I, under general anesthesia, under the microscope, I will use a Chalazin clamp. I will insert the Chalazin clamp and fold the lid out. And then under very high magnification, which is like 10, 15, with the 15-degree blade, I will resect the block either of the ectopic cilia or the distichia. It has just been, we're using this technique forever. And sometimes if you have the entire lid margin involved with distichia, you wonder about the meibomian gland function, but you don't resect the entire meibomian gland, you just resect the base where the distichia generate. Or originate, should I say. And but it doesn't come to my head right now who the author was, but this year there's a publication, say February or something like that, about the results of the unblocked resection. Sorry, I can't quote the paper, but it's there. Unblocked resection, distichiasis results. And I can only clinically share that we've done this for years and we're very happy. And I'm glad somebody looked at it and published it. So then again, we use warm compresses and tacrolimus. We added this on to the cyclosporin and the hyaluronic acid for a short period of time, and the blockage resolved, and we went back to the normal BID cyclosporin. He was doing fine. What caused this blockage? I don't know. Maybe a course of inflammation that started the blockage, and then once you're blocked, you can't get rid of the secretion without any help. And as soon as you continuously, on a regular basis, put on warm compresses, you can resolve the situation. So this is when we started. We had really bad tear breakup times, and they went up after 4 months. And we also had a lot of like watery eyes, a lot of tear film in the as the tear meniscus height, and that went into normal range. So then we have a continental bulldog who had a non-healing ulcerations, GED, and he probably also had tear film problems to start with. And you can see that, this is just a side note, along with the ulceration, he had uveitis symptoms. Reflex uveitis, quite severe in that case. So this healed, and then 3 months later, he comes back and he has this haziness in the area where the scar was, where the ulceration was. You can see that there's some depigmentation, there's conjunctivitis, swelling of the conjunctiva. And the Schirmer tear test one was 18 in the right eye and 21 in the left. And then if we look at the breakup time, it's really, really short, 1.4 seconds in the right eye and 0.8 seconds in the left. That's like, it's gone. And the interferometry showed bad image. Meibography showed blocked ducts. And we put on warm compresses again. We used tacrolimus, hyaluronic acid, cornea cleared. The scar and the infiltration went away and the problems resolved. This is a follow-up after 3 months. Remember these really bad tear breakup times. And this is the left eye where the scar was, where the ulceration was. And then we go into normal range, like really normal range and almost normal range. And the meibomian glands start to work again with the warm compresses and the tacrolimus, and the tearing goes down. Look at the time frame. Everything takes time in the cornea and more time to start changing the surface disease, to start changing tear film. It's nothing that is quick. It's not like you install a drop and the problem is gone. Richard?
Yes, I pulled up the reference that you mentioned and posted that in chat in YouTube for everyone. It was Gomez et al. And then there's another question. Have you ever encountered meibomian cysts in dogs? And if so, which breed?
Meibomian cysts would be that it would be difficult to diagnose or to differentiate if it's just an inspisation, I guess, or if it's a true cyst. I would wonder without histology to make a difference clinically. Inspissated, yes, many. Were they cysts? No, I don't know. Sorry. I think I couldn't answer it more precisely.
And then there's 2 more questions that came through, Dr. Mariana. When or why do you use tacrolimus versus cyclosporin?
It's more a clinical decision. I would use tacrolimus first choice in a dog that had aqueous deficient dry eye. That would be my first choice. And if we have like below 10 millimeter Schirmer dry eye, we would start with a combined therapy, cyclosporin plus tacrolimus together. And initially, as I mentioned before, we would always use a short term, depending on the course, steroids as well to reduce the inflammation. When we have a aqueous tear film deficient, lipid phase deficient, evaporative dry eye syndrome. Sorry, I was thinking while I was talking. I would rather go to tacrolimus because cyclosporin has a much more lacrimogenic effect. And if you have a an irritated, watery eye. I personally have the feeling, without having any backup of comparison tests or whatever, it's just a clinical decision, that if I place an oily drop, and cyclosporin typically would come in an oily base, that is lacrimogenic, and I have a very watery eye, that is epiphora and irritation, I would not want to add more stimulus to the lacrimal gland. I would rather want immune suppression or immune modulation at the lids. And I think I have the clinical impression that tacrolimus works better, but there's nothing to back it up. And I think it would be very hard because it's individual cases and individual reactions. What we also noticed is that so many dogs are allergic that are presented with evaporative dry eye, and that also falls in the categories that we see so many Frenchies. And I think every French bulldog is an allergic dog. And then they are very intolerant to many medications. So that adds on, and it seems that tacrolimus is more accepted, more tolerated, better tolerated than cyclosporin. Ointment anyway, like Optimune would be horrible in those, in our hands, horrible in those cases. Okay. Okay, so I just wanted to point out that this takes long. This is another interesting case that had chronic mucoid discharge, and there were topical antibiotics applied and combinations of steroids and antibiotics, and there was no change. And she was only 3 years old when she came to us first. And this is the presentation, and she had hairs just sitting there, and you can tell that either the blink reflex is not intact in those cases if you have this presentation, or the tear film layer is deficient. This is the clinical diagnosis when we see a dog with this slimy accumulation nasally and an accumulation of debris in a dog, and this is not even an exophthalmic dog, it's a Norfolk Terrier. So the clinical suspicious diagnosis of evaporative dry eye was made. And this is showing it again. And then we looked at the eyes, and we looked at the blinking, and that was very reduced. We had 6 blinks and they were incomplete, so it didn't close completely. Yes, Richard, are you waving or just there?
Yeah, no, so I'm just popping in and showing my face whenever there's a question.
That's great.
So this is from J.L. Joseph. Which Evo tears would you recommend? Those with omega or without? And what do you do to choose that?
First, we had only the regular were on the market, so we didn't have any choice. We just used it and we liked it as long as the animal would tolerate it. And there are some that tolerate it great and it's a game changer, and there's some who will just not tolerate it, or same, it doesn't help. So we used the regular one, and then the omega came on the market later, and I told you that the meibomian glands as well as the lacrimal gland needs essential fatty acids, and this has been demonstrated nicely by Brazilian colleagues. So why not add the omega fatty acids if you have them, and you can add them topically as well, and they are right there. So actually we are just using the combination, but there's no comparison. Nobody looked at the comparison scientifically. That's all I can say.
Okay. There's a comment as well, but I have to get some clarification because I don't understand a part of it. So I'll get back to you on that one.
Okay. So just as a side, the blinking was not regular. The staining, we did vital stains, they were diffusely positive, and we had multiple punctate areas. Schirmer tear test was 20, Schirmer test 1 was 20 in both eyes. And if you watch closely, you can see in the first slice as well that you can see all those meibomian glands. It's like a pearl bracelet that you can see the meibomian glands popping out here. It's amazing. And then this is the fluorescent test. So this is the interferometry. You can see that it's again, this is a little bit better. This is almost white. It's a sheet. So I'm just showing you the images, but the software brings you the comparison table and you can click on the scale. You can see the breakup was 4.8 and 5.4 seconds, so pretty low. And the meniscus height was really high. You can see that the eyes are watery, full of tears. So in conjunction, the two things together, no waves visible or hardly any waves visible, gives you a thin lipid layer together with a low tear breakup time, makes perfect sense. And then we looked at the meibomian glands. In total numbers, they were reduced and they were all dilated and filled with secretion. So this is what we had. We talked about this and we applied the Evotear strap, tacrolimus, and we looked after 3 months and it had clinically improved, but the meibomian glands were severely blocked. And we expressed the secretion and we used the warm compresses. And here you can see the expression of the secretion. There's some brown, ugly discharge here and some yellow, very sticky discharge here. So what we do is we actually mechanically express those glands to alleviate those meibomian glands from the secretion that they can start producing again, because the compression of the ducts will cause dysfunction or will even make the dysfunction worse by a mechanical atrophy. So you have to combine mechanical therapies, lead surgery, immune stimulation, immunosuppression with tacrolimus, or with steroids, anti-inflammatory drugs, and lacrimal mimetic drugs at the same time. And you have to find the right mix and you have to be prepared for frustration. It's much easier in my hands to treat an aqueous deficient eye, to stimulate the tears, to increase your regimen, to increase your dosage, to check all the reasons that can cause aqueous deficient dry eye, than to treat lipid layer deficient, meibomian gland deficiencies, evaporative dry eye. That's very frustrating for all involved. And I think it's a really, really quality of life influencing disease. And the good thing, if there's a good thing, is that many owners also have the same problem. And they, if you listen to them or they start talking, they will tell you, I use tear replacement like 3 times an hour. And imagine the sense of this treatment is you wash away all your good tears that you have left. So if the owner suffers and they know what dry eye feels, they are prepared to help the dog. That's the only good thing. Richard?
Yes, Ingrid, I have the clarification on the comment from Dr. Mariana. She had made the comment that she feels that the oil component in the cyclosporin drops are what are due to the reactions in allergic dogs, specifically between corn oil and almond oil.
Correct. This was the comment.
Yes, I just wanted to make it clear.
I would agree 100%. Still, the oil will cause more discomfort than typically than the watery drops. In my hands. So if we look at the digital ocular surface analysis, you get more detailed information about the tear film. It's non-invasive, it's fast once you get used to the software, and it gives you more objective results than the, for example, the tear breakup time, the classic tear breakup time, or say the Ferning test or anything like that. I would make the point that you first start analyzing with your first exam, and then you start treating, and then you also monitor. So you go back and do the same exam like 3 months later, and you check where do I need more, or what do I need to tighter, what do I need to change, what can I add, or you know, how to fine tune the therapy. So I think you use it several times on the same animal. It's there, it doesn't need any maintenance, it's quick. I can hardly think of anything that was simpler to use to start with. So in summary, take home message, what I talked or what I would like to stress is that ocular surface disease is tear film disease, full stop. It's there. Every time you have anything on the cornea and in the conjunctiva, remember that wheel that starts turning, you will have tear film disease. Either transient, and you have to watch out for it, after cataract surgery, after keratectomy, after lid tumors, after lid surgery. You will always have a disturbance because you placed a stimulus on the lacrimal functional unit, and that changed the whole system. And if it's transient, you're lucky. If it's chronic, you have to deal with it. KZS is not always aqueous deficiency, that's obvious. We talked about evaporative tear film disease, I think, for 1.5 hours now. Most patients have a reduced tear breakup time and an increased tear production. So Schirmers are high, and the tear breakup time is very low. Amazingly low, nothing but could be measured with the classic tear breakup time. Usually you have some of this compensatory, glucky, slimy discharge where nobody has shown if this is a goblet cell hyperreaction or whatever. It's difficult to show the function of the goblet cell. Mechanic factors play an important role, and this is when we think about brachycephalics, or we think about loose lids, the opposite, like in all those large dogs that have ectropion or pocket syndrome, or V-shaped entropium, rhomboid lids, whatever. All the tumors, all the dystichia patients. So we have lots of factors that could interfere with an even healthy tear film. Meibomian gland dysfunction, MGD, that's like a word in human ophthalmology. We could use it when we suspect it. We don't know how we evaluate really good the mucin layer and the corneal villi. We don't evaluate them at all, actually, currently. We don't know about the inflammatory mediators, not much about that way. Anyway, and for me, this is a huge part. Allergies as game players, it's very important, and we're just starting to look into that in veterinary ophthalmology. The diet, does the diet play a role? Definitely, because the diet is involved with allergies, and so many dogs change their diet and their eyes get better. That's something that is just a clinical word. So take-home messages, there's much more than the Schirmer tear test and the vital stains. There's much more, and there's so much we don't know. We have refined diagnostics. They might still be at the beginning, but we have to begin somewhere, and we have to be more precise, because we need better understanding of the whole thing, and we need to apply better diagnostics and better treatment options. And we can't do that if we just suspect a disease and treat it with topicals. We always watch to try to treat the cause and not the effect. I told you that in many times we can't find a cause or we can't treat the cause. We still try, and we try hard. And there's so much more. There are new strategies like the intensive pulse light, and I'm sure there's like every month there's new papers coming out, and this is actually something that will definitely change over the next months. So stay open-minded. I'm sure there's much more to come that we can help the dogs to feel better, because this is a life quality changing disease or situation. So I'd really like to thank you to be there, if you're still there, I don't know. I would like to point you to, we have a Facebook site. Sometimes we just post nice pictures when we don't have time. Sometimes we have interesting cases, so I can see you there. And I would like to also point you to SBM. That's the user of the surface analyzer that we just talked about. They put this atlas together, and they just wrote me today that I can point to it during the webinar. It's ready. It's there as a PDF file. It's ready to be spread. So if you're interested, you can mail me or SBM or Envision, and they will definitely forward it to you. And it's going to be printed in September. It's actually just a collection of cases, and shows you more slides and information about what we hardly know is the ocular surface disease. Thank you for your attention. I'm happy to introduce to entertain any questions. We still have a little bit of time.
Yeah, there's a few questions, Ingrid. So first one, Dr. Morrell, have you studied the interference of the caruncular trichiasis on tear film stability? And then there's a second part to the question. Do you always recommend the surgical correction for that?
Nasal caruncular trichiasis, I think it's really important to get rid of it. And I would always recommend to treat it surgically. I mean, obviously all the pucks where we did like those extensive studies over years, we could show statistically that the sooner you operate them, the fewer lesions are on the cornea, the better is the long-term result. And apart from that, the dogs change their attitude completely because they have chronic pain, chronic irritation. That's just something that nobody actually looks. It's so much more impressive to treat a cataract than to treat a chronic tear film disease that you can hardly improve. But if you have factors that you can improve, you always go for the factors. And it has been shown that the pugs improve, that the Shih Tzus improve, that the Frenchies improve. Yeah, definitely. Clear yes.
Okay, and then we have a question from Dr. Mariana again. Regarding tacrolimus, do you use a compounded cream or drops?
Oh, tacrolimus, we use drops, compounded drops, and we use an ointment that is in the market, I think in Europe, at least. It's called Protopic. It's a skin ointment, and it's very well tolerated in the eyes, and we've used it for years. It's the only commercially available tacrolimus Protopic for tacrolimus product on the market for external use.
All right, and then we have a question from Ramani Chandraskara. Do you notice changes in my biography following temporary tarsorrhaphy? Do you have any on that?
We haven't checked. We would use the temporary tarsorrhaphy after surgery, or in cases with a facial nerve paralysis, or after a globe prolapse. So quite drastic stimuli, noxious stimuli to the tear film. And I've never looked at the tear film before that and then after that. but the clinical impression is that it helps the tear film. That's why we are doing it. But I couldn't give you numbers, no. And we didn't look exactly at the myopography. Is there any, would you wonder?
If you have a follow-up question, go ahead and type that into the chat. While we're waiting to see if anything comes back on that, there's a question from Dr. Zhao, Alfredo Kleiner. When do you recommend using episcleral cyclosporin implants?
When the owner either can treat the animal on a regular basis or not as often as we want to. Like they can treat it before and after work, but not 3 times daily. And if we are not having enough results with the topical application before we move on to parotid duct transposition. We don't use it commonly. I wanted to mention about the tarsorrhaphy maybe before the question comes back. I just wanted to mention that there was that the French bulldogs with the chronic ulcerations as cats, they just drive us crazy here. We see several a day, and they just don't heal. So it's really a focus of interest, and we have because we need to look at them. And in the idea of changing the protocol and improving the healing, we went through a time when we did tarsorrhaphy because I thought at that time that exposure played a major role in the disturbance of the tear film and impeded healing of the chronic ulcerations. And we did, I would say, at least for 3 months, we did tarsorrhaphy in every single scat patient of French bulldog. It didn't change a bit. So we got away from it. So, but I'm open for the suggestion. It just drives us crazy. Any more questions?
And then we have another question. Have you come across tacrolimus side effects when using them long term, such as intermittent epithelial blisters on the eyelid margins or papillomatous-like lesions?
Papillomatous I haven't seen. I have heard about it, but I haven't seen it. We do see once in a while that they tolerate dogs, we're talking about dogs, tolerate tacrolimus for a long term and say 2 years. We just had a patient like that. And then all of a sudden they develop an adverse reaction and you think it can't be because this has been on for 2 years and it went fine and it did the job. But yes, it happens. And sometimes you can get like blepharitis, and chronic blepharitis, the hairs go off, but it's not typical. It's just something that comes to my mind. Not common.
And then we have a question from Antonio P. Have you tried interferometry and non-healing ulcers in rabbits?
Oh no, I haven't. But we have maybe intuitively used tacrolimus on a series of cases with some result. I wouldn't go as far as that to recommend it, but I could imagine that there's some neurologic role involved. But I'm not aware of somebody has been looking in that histologically.
Okay. At the moment, that's it. We'll see if anything
we're
comes through.
Almost through the time, so we're probably going to be shut down in a minute. Thank you for, first of all, thank you for you, Richard, and also thank you for the organizers, and thank you for our Indian colleague, and I'm not trying to speak out his name, who is hosting the Zoom meeting. Thank you. You're there in the back. I can see you lurking. Okay, so there's no more question. I wish you a good night and hope you learned something about tear film. You get inspired to look at it.
And also from AmVision, there's a big thank you to everyone that participated and joined.